I became interested in medicine when I was 8 years old because of my pediatrician. I felt a close relationship to that pediatrician and decided actually at the age of 8 that I wanted to be a pediatrician. I was born in New Orleans, lived in New Orleans most of my life, and that's where I grew up until about 1992, except for a short stint in the military. When I finished my internship, I went into the Navy, and I was a general medical officer in the Navy for 3 years. I went to Vietnam with the 4th Marine Division as a battalion surgeon, came back to New Orleans and finished my last year of service as the Chief Medical Officer for the 8th Naval District. When I first started medical school, I did want to be a pediatrician. That was my goal. But most of my medical school training and the job that I had in the Navy really was more general medicine, so I consider myself very well versed in not only pediatrics, of which I'm board certified, but also I feel very, very comfortable with family medicine. Over 25 years in emergency medicine as well. Basically, I feel very comfortable doing emergency medicine as well as pediatric emergency medicine. It's extremely difficult to keep abreast of all the knowledge that comes out on a yearly basis and to sift out the important things to know and those that are not important to know. But it's not an easy task. It's something that you have to do on a daily basis, really. I lived in Cartagena, Colombia from the age of 10 to 12. When I came back to the United States with my family, the Spanish was not something that was continued, so obviously I lost some of it. But the ability to have the accent and to learn the language very quickly still stays with me. I worked in the Rio Grande Valley in Edinburgh and McAllen, Texas for a year and a half, running an emergency room down there. 50% of my patients didn't speak any English at all. So I'm fairly comfortable with medical Spanish and actually most other things. Diabetes is a very complex disease, as you well know. It's very prevalent in the Hispanic population. We don't actually take care of diabetes. We do diagnose diabetes. We do take care of the patient if there's a problem when they come in, but as far as the actual day-to-day management of the diabetes, that is usually done by a diabetologist or their primary care physician. This facility is North Central Urgent Care. It is one of the premier urgent care facilities in the area. It was opened 10 years ago. We have a very large client base who have come to know us and appreciate the work that we do. Our role really in the medical care of the patient in this community is one of obviously urgent care, which could be anything. It could be a sore throat, it could be a broken bone, it could be a laceration. And we function pretty much as a minor emergency care facility. Actually save the patient a great deal of time and resources if they do not have to go to an emergency room. In this facility, we have a duty and an obligation to our patients not only to treat their initial complaint, but if necessary to refer those patients to the appropriate facility or to the appropriate specialist. In many cases, we do become the patient's primary care physician on a temporary basis. It gives me great joy and satisfaction to know that I've made a significant difference in someone's life. I enjoy seeing those patients again, knowing that I've made a significant contribution. Many times I'm asked, why don't I retire? And my answer is always, I really, really like what I do. And that's a fact. Okay.